opportunity to talk about what's coming new in mesh. These are my disclosures. None of these will be relevant to the content that I speak about today. So before we start talking about what's coming new in mesh, it's important to consider the timeline of mesh development and the history of what we've done. We've gone from using very heavy meshes decades ago to lighter meshes to ultralight meshes, looking at different base materials. And now you can see the pendulum swinging back towards heavier weight meshes again. Certainly biologic meshes have come, some have gone, some made of human and animal tissue bases. Absorbable mesh, synthetic absorbable materials are certainly here to stay, and that's going to be the focus of a lot of what we speak about. Hernia prevention and mesh that can be used for that has been a hot topic for several years. There are new vendors entering the mesh space every year, and mergers and acquisitions, both in the mesh developments side as well as hospital mergers, certainly play a role in the mesh materials that we all have available to us. I think it's unlikely that any of the new materials in development are going to result in wholesale changes or paradigm shifts for many of our patients. For healthy people with relatively straightforward hernia conditions that need our help, these new materials are probably not going to affect them greatly. There might be some refinements in existing ones that help, but most of the development, new technology is going to supplement our existing materials for more complicated patients, such as the one listed below. New product information is pretty heavily guarded by the companies and manufacturers until FDA approval is reached. These are proprietary materials and they do have a significant amount of intellectual property associated with them. Non-disclosure agreements are common for those who participate in the development of the materials as well as some of the early testing. And additionally, from my standpoint, I think just like many of us, I interact with several mesh vendors. None of these are willing to share very extreme details of what's coming next for public consumption at this point. And the content I talk about today are things that are somewhat in more generality. But when we think about mesh, we always should recognize the fact that we don't have a perfect mesh material for every hernia we see. We just don't. But efforts in development should look at how do we get better? How do we get closer to that ideal? So if you think of what the ideal mesh should be able to do, it's got to be very strong, should conform to a patient's abdominal wall. We obviously want good tissue ingrowth. And this is something I think we all recognize more and more, is that it should behave more like our own tissue. So when a patient fills out a Carolina's Comfort Scale or Hercules or some other quality of life tool, you want mesh that's not going to make them be reminded at all times that this feels different. Obviously, we do not want intense adhesions to the viscera, to the intestine. We want meshes that either do not become infected or that we can treat through an infection if it occurs. Minimal foreign body reaction, chemically inert so they can stay on the shelf for a long time, and low cost. And obviously, this material does not exist today for every hernia that we see. But goals in mesh development obviously are done to improve patient outcomes, reduce complications, infections, the rate of mesh explantation. But there's a lot of needs to be met. Certainly we think of the patient's needs. Patients want a durable, successful operation with very few misadventures. Surgeons' needs are also important as well, particularly for those of us who are familiar with certain materials and have a good success rate and good outcomes with them. If those meshes are not available or if they change significantly, it can certainly impact the way we take care of our patients. Hospitals' needs are important. Hospitals care very much about their reputation, about quality and outcomes, and they also care about their supply costs, and mesh is going to impact those on both sides. It goes without saying that mesh companies have vested interests. I think it's fair to say that their interests are in achieving good patient outcomes, just like all of ours, but they may have financial considerations that need to be reconciled when treating our patients. And lastly, payers have an interest in this. We are certainly not at a point where government or commercial payers are ready to say, we will pay for more expensive materials for certain cases if there is a guarantee that the outcome will be better. But make no mistake, payers pay attention to materials that are used, and at some point, someone's going to question the efficacy of things that have significant cost disparity. So what has come in mesh? These are the big three historically: PTFE, polypropylene, polyester, the very basic vanilla meshes that people have been using for decades with pretty good success rates and track records. So those have come, but they're not going to go away. The other things that have come are the newer materials. And this list is by no means comprehensive, but these are some of the most commonly used absorbable materials available: poly-4-hydroxybutyrate and polyglycolic acid trimethylene carbonate copolymers. Those are both absorbable synthetic meshes. There's a trimethylene carbonate lactide glycolate multipolymer that is a staged reabsorbable material, meaning each one of these materials will be reabsorbed at different time periods. And then we have a different generation of composites that are not the adhesion barrier, right? So we all remember early intraperitoneal meshes that had a film on them to reduce visceral adhesions. These are composites that instead are made out of a permanent material on the inside, surrounded by an absorbable material: a polypropylene with small intestine submucosa, a PTFE mesh with polyglycolic acid trimethylene carbonate on the outside. Those are done to try and maintain some permanent tissue layer, but use the benefits of an absorbable material to try and achieve better outcomes. So permanent synthetic mesh advances, I think we're going to continue to see new construction. So what do I mean by that? So if you look at meshes that were historically prepared in braided materials, multifilament, or solid sheets of mesh, those are now available and will continue to be available as monofilament meshes to try and maintain some of their historical benefits of pliability and strength, but reduce the concerns that are associated with infection and braided mesh or sheet-based meshes. At the same time, looking at the monofilament mesh, that historically the most commonly used one has been polypropylene, trying to maintain the great tensile strength, but achieve some better elasticity and things that are going to help that mesh behave more like autologous tissue. And then the third are going to be refinements in that hybrid mesh technology, those composites that contain permanent and absorbable components. Right now, the majority of those available have a substantially greater proportion of permanent material on the mesh, meaning when that reaches its final resting place and all the absorbable material is gone, there's more permanent material than there was absorbable material. That may not be the case in the future. We may see mesh development, and I anticipate that we will, where the majority of the base material is absorbable, and what's left at the end is a small component of permanent material that's able to achieve the same recurrence-free outcome. Biosynthetics or long-term reabsorbable or synthetic reabsorbable meshes, whatever we call them. This is a table from a paper of Brent Matthews and Corey Deakins from 8 years ago now. And if you look at this list of absorbable materials, these are still all commonly used. Their reabsorption times are different, the way they're degraded is different, and their base composition is different. To this day, we are not able to say which of these material is better than another one, but this is just a snapshot of what we're going to see in the absorbable mesh space in the future. So what's coming? So we're going to want to continue trying to accomplish all of those objectives of an ideal mesh material, but to be able to do so and meet the needs of these varied patients, the complex patients, a diabetic, obese patient with incisional hernias, someone with a small, very straightforward hernia, an elderly patient who's had several recurrences, or someone who's had a prior incisional hernia repair, has a fistula and a recurrence, the total disaster that unfortunately we see. Mesh materials should be able to help us address the needs of each one of these. So what do patients need? I think it goes without saying that patients are all looking for no recurrence or recurrence-free survival after a hernia repair. They also want minimal disruption to their life and to their work in terms of activity restrictions, pain, mesh sensation, long-term consequences. I think they are also asking us as surgeons to justify the rationale for why we are using mesh. So questions of not, I'm worried about the lawsuits. It's now the questions are, can you do my operation without mesh? Do I really need mesh? What is my mesh made out of? Okay. I think these are early questions. And what they're really getting at is what risk of hernia recurrence is going to be acceptable to them, right? So we all want no recurrences. But I imagine a day where we pose questions to patients and we frame it as, we could repair your hernia using a permanent material with a 3% recurrence rate. And at the same time, we could repair your hernia with, say, an absorbable material that carries a 15% recurrence rate. At some point, those two numbers will be close enough to one another where patients will elect to have non-permanent mesh materials. I don't know where that is, and I don't think any of us do, but there's no question that we're going to continue to move in that direction. What do surgeons need? What do we want? We obviously want any way we can to improve our outcomes. Certainly, patient factors play a role in this. Operative technique does, and mesh material certainly does. I list hernia prevention down there. That's certainly been a hot topic, but probably not the focus of what we're going to discuss today. And then some nuts and bolts things that seem very, very basic, but no doubt each one of us have encountered this. Mesh sizes and the portfolio, particularly of newer materials that are available, is limited. And that's understandable. When a company develops a new material, it's not going to be available in 6 different sizes on day one, right? Because that's not cost effective from a development standpoint. On the other hand, I think we have all been doing operations where we'd say, boy, I would love to use mesh number 1, but I don't have it in the right size or shape, and something suitable is not available. So I'm going to switch to use mesh number 2. I would expect those days to be numbered. Secondly, what's the mesh profile? Can it fit down a trocar? I think any mesh that can't be used laparoscopically or robotically either needs to have a true niche for a patient that is specifically designed, or it's going to be limited in its applicability. And cost considerations go without saying. Needs from the mesh industry, I think no question, our industry partners have recognized patients' desires for materials that are non-permanent, and we are very much in the early stage of that. Every vendor I spoke to either has a non-permanent absorbable mesh material in development that will be launched in the near future, or they have an existing material that's going to continue to be refined to try and take advantage of patients' wishes for non-permanent mesh material. And there are going to be a lot of options. What that's going to lead to is surgeons and patients, we are going to be inundated with new products with a lot of options, but with a lot of questions. What's the right material? And if you go back to that table of the existing absorbable mesh materials that are currently available, it's hard to say one is the best and one is the worst. That problem is going to be increased in size and scope. So outcome measurement, I think that's what's coming next for us and for new mesh, particularly with newer absorbable materials. These new materials need data. Our patients are going to demand it, and we are going to want it. I think this is going to be a great opportunity for collaboration and partnership with the mesh industry. I put up these 3 publications. These are all examples of multi-center prospective evaluations of newer mesh materials, some absorbable, some hybrid composite materials. But these were all done in partnership with industry. There are names on these publications from people in this room, certainly recognizable to all of us. And the benefits of the data that came from each one of these cannot be overstated, okay? Without the willingness for groups of surgeons to get together and say, how are we going to look at these ones, and industry to partner with them in doing so, we wouldn't have the data that helps us justify the use of some of these to our patients and to our hospitals when we ask for new materials. So our mesh advances are going to continue. I think we're going to see this in 2 main directions. The existing permanent materials that we tend to use for lower risk, lower complexity patients will continue to be refined to aim at those quality of life measures. How do we say we are going to use a mesh that is historically braided or a sheet-based material and use that in a monofilament fashion to take advantage of some of those materials' baseline benefits? At the same time, we're also going to see development of new absorbable materials for higher risk patients and for mesh averse patients. This is going to create a lot of opportunity to collaborate and measure outcomes together in partnership with our industry colleagues to help us arrive at the correct data to make the right decisions for our patients. Thank you again for the opportunity to discuss this today.